Boa noite, colegas, amigos da ABAD, Associação Brasileira de Estudos de Álcool e Drogas. É um prazer muito grande estar aqui com vocês para falar de um tema tão importante. Hoje nós vamos ter uma professora, pesquisadora da Universidade do Texas, doutora Ângela, que vai falar, está entrando agora, vai falar sobre a experiência americana na prevenção HIV entre usuários de substância. Então, conforme combinado e já anunciado previamente, nós vamos ter que conversar em inglês, né, mas vocês vão poder enviar perguntas em português, a gente vai tentar traduzir e conversar com ela. Então, nós vamos de imediato aí passar para uma conversa em inglês e ouvir a palestra da doutora Ângela. So, Dr. Ângela, nice to meet you. How are you?
I'm good. Thank you for inviting me.
Thank you. It's an honor for us to meet you, and it's a pleasure for the Brazilian Association of Alcohol and Drug Studies to address this relevant theme for us related to HIV risk-taking behaviors, stigma, substance abuse. As you know, our country is a poor country, low and middle income country, and we have a large poor population with several vulnerabilities and social economic problems. So it will be very important to us to listen about this issue. So I'd like to introduce you for 1 minute for people know you a little bit better. So I'd like to read your CV, the small CV, not the whole CV. So Dr. Ângela is a PhD. She's licensed psychologist with clinical expertise in evidence-based treatment for substance use disorders, anxiety, and depression. She also has a specific interest in women's mental health issues. Dr. Head's research interests include substance use, HIV prevention, psychocultural correlates of health risk, racial and gender-related disparities in mental health and coping. Dr. Heads also completed a postdoctoral research fellowship in the Center for Neurobehavioral Research on Addiction in the University of Texas Health in Houston. And she joined the Department of Psychiatry and Behavioral Science as an assistant professor in 2015 to continue her research and clinical work. She has also been actively involved in training and clinical supervision of psychology, doctoral students, and psychology interns. So again, it's an honor to us to have you here tonight, and please, we'd like to hear you.
Thank you so much. So I was asked to talk about the United States perspective as far as HIV prevention with substance users. And so I will do my best to cover as much as possible today. There's a lot going on. I've chosen to outline my talk according to these basic objectives. So I want to provide an overview of HIV in the United States, including recent trends. I will talk about the connection between substance use and HIV. I will talk a little about the role that behavioral health providers can play in screening and prevention. I'll talk some about barriers and facilitators to HIV prevention. And then I'll talk about some recent and ongoing research in our center, and also a services delivery project that we have going on at this time as well. So in 2019, in the United States, our Department of Health and Human Services announced the Ending the HIV Epidemic plan for the United States. This plan includes 4 pillars. These are areas that were determined to be important to address if we want to achieve the goal of ending the HIV epidemic. And so those four pillars are pictured here. The first is to diagnose. And basically what we're saying is that we want to diagnose all people with HIV as early as possible. A problem in the past and currently as well is that there are a lot of people who are not aware of their status because they don't engage in HIV testing. The second pillar is to treat those diagnosed with HIV as quickly as possible. And the purpose of that, of course, is to try to reach a sustained viral suppression for an individual who is diagnosed with HIV to prevent the possibility of them transmitting HIV unknowingly to someone else. The third pillar is prevent, and that's where most of my focus will be today. The prevent pillar basically says that we want to prevent new HIV transmissions by using proven interventions. Those proven interventions include pre-exposure prophylaxis. We refer to that as PrEP for short, and things like syringe exchange programs. And then the fourth pillar is to respond as quickly as possible to potential HIV outbreaks to make sure that we prevent transmission to others and also get treatment services to people who need them as quickly as possible. So our overall goal here in the United States is by 2025, we want to reduce the number of new HIV diagnoses down to 900,588 by 2025 and down to 3,000 by 2030. It's a very lofty goal, I'll say. Currently, how are we doing? So as of 2019, these data that I'm talking about are from the Centers for Disease Control and Prevention. In 2019, and that's where we have the most recent and complete data, there were 36,801 new HIV diagnoses in the United States and in the dependent areas of the United States, so places like Puerto Rico. The majority of these cases were among gay and bisexual men, also known as men who have sex with men. So 69% of the cases were among men who have sex with men. 23% were among heterosexuals, people who have sex with opposite sex partners. And then 7% were among people who inject drugs. So I'd like to just take a moment to kind of look at the trends about how we got there, or the more recent how we got there to that point where there are just under 40,000 per year. So these are trends from 2010 to 2019, and these are incidence estimates. And this is data collected from the National HIV Surveillance System through December 20th. From the 50 states within the United States, Washington, D.C., and Puerto Rico for adolescents and adults ages 13 and older. And so you can see each year there's either stability or some really small decreases. However, by the time we get to 2019, if we just compare 2019 to 2010, that asterisk next to 2019 tells us that the difference is significant at the 0.05 level. The other places where there are not asterisks, where we just have little incremental changes from year to year, were not considered significant, but overall, the decrease is significant. I usually like to look at kind of differences in HIV incidence by different demographics. And so here is some information on the decreases from 2010 to 2019, but it separates out these decreases between people who were assigned male at birth versus those who were assigned female at birth. And you can kind of see, you know, there are modest changes, just like we saw on the previous slide, but the majority of the changes is among the male population. And really, when you look at the female population from about 2013 on, that line is pretty flat. So we're not seeing a lot of changes there. And there are some people who have said that our HIV prevention efforts stalled around 2013. And the primary reason for that is that the prevention efforts that are effective aren't reaching everybody. So this is just another way to look at the difference. This compresses it a little bit. This is just 2015 to 2019. And it more clearly shows that for men or for males, the decrease is greater. And for women, females, transgender male to female and transgender female to male, since the dot for 2015 and the triangle for 2019 overlap, that indicates that the differences are not significant. That is really considered to be just an incremental change. There are also other sociodemographic disparities to consider if we want to truly understand HIV in the United States. So for example, the new annual HIV diagnoses rates are much higher in the southern regions of the United States than in other regions of the United States. And the CDC has identified what they call priority jurisdictions, where the rates of HIV are significantly higher in those areas than they are in other areas. And most of those jurisdictions do fall in the southern United States. And so I'm in Texas, down there at the bottom in the south. And within Texas, there's a specific county that has been identified as one of those priority areas. And so it's quite a big deal if you know, you're having certain whole states that are identified, and then you're down to a specific region within a state, such as Harris County. That is where I am. Houston, Texas is in Harris County, and it is one of the identified regions with high rates of HIV. There are also differences in other demographics. So here are the disparities by age. So I've said 2010 to 2019, things are decreasing. But I think this was very interesting and shocking to just see that most of these age groups, the cases are decreasing. Most notably, 13 to 24 cases decreased by 46% from 2010 to 2019, which is great. But in the 25 to 34 year age range, cases increased by 35%, which is pretty significant. And this is just another way to look at some of the disparities. I also like to look at things by race and ethnicity. What we see here is the green line, or teal, whatever you want to call that color, shows the overall population for these different racial and ethnic groups, whereas the purple line shows the HIV rates for each of those groups. And so if you look at the bottom, the second from the bottom, that's the majority population's white. And we see that population makes up about 62% of the total population and about 25% of the HIV cases in 2019. But for Hispanic or Latino populations and for Black and African American populations, where we are by numbers the minority, most of the cases are there. It's also important to understand how HIV, or the major categories for transmitting HIV according to the statistics. You know, I was asked to talk about substance use. And so we see here that the majority of cases are male-to-male sexual contact, followed by heterosexual contact, and then injection drug use. And those are the highest categories for HIV transmission from 2010 to 2019. This is a slightly different way of looking at this because a lot of my focus is on working with women. This shows that while male-to-male sexual contact is the highest transmission category for men, it's heterosexual sexual contact that is the highest category for women. So women make up about 19% of the overall cases every year. And on that previous slide where I showed you how the cases are declining from 2010 to 2019, but for women, it's remaining relatively flat from 2013 to 2019. The majority of those cases are from heterosexual sex, and then followed by injection drug use. And we'll talk about some of that a little bit more later. So speaking of substance use, so we here all know that substance use is associated with HIV and other sexually transmitted infections. Injection drug use is one of the transmission categories tracked by the Centers for Disease Control and Prevention because it's a direct route to HIV. We know that, you know, sharing needles with a person who has HIV or any other infectious disease for that matter is a very risky activity, which often results in transmitting HIV or that other infection. And so injection drug use is definitely important to consider. But the thing is that most individuals who use substances do not inject drugs. So the injection drug use doesn't account for all of the HIV risk among individuals who do use substances. So we have to consider other mechanisms. So what is it about substance use other than that direct route from injection that can contribute to the higher rates of HIV in the population? And so some of those things is, of course, substance use results in altered judgment, altered cognitions. Because of those changes in the way people think and the way people make decisions, then there's going to be a greater likelihood of engaging in behaviors that are riskier. And there are decreased inhibitions. So there's less of that little voice telling us that we should not be doing such and such occurring when we're on substances. So with that loss of inhibition and the changes in cognition, then some of the choices made when people use substances can result in increased risk for HIV. When we're talking about substance use, we should also consider the level of drug use. By that, I mean like the severity, how often, how frequently the person uses the substance, and the type of drug. I've mentioned gender. There are differences in the severity and outcomes for substance use for women compared to men. Partner gender is also a factor. General mental health as well as trauma history are also factors to consider when assessing a person for their risk for HIV when they are using substances. So speaking of types of substance, alcohol. So very commonly used substance, so commonly used that, you know, there are people who say there's not really a problem with it, but it is well known for altering people's judgment and resulting in riskier sexual behaviors. Again, I mentioned the decreased inhibitions. People often use alcohol as a social lubricant. And I have the picture of the guy there with the glasses. And there's a term here in the United States called beer goggles, where as a person who drinks a lot will suddenly find all types of people attractive that they wouldn't have found attractive before, and may you have poor judgment and engage in activities that they would not have if they had not been drinking. And some people also see that kind of that release of nervousness and anxiety that comes along with drinking alcohol as being a sexual enhancement. So in the introduction, Félix mentioned that I supervise and train interns and psychology students. And so I wanted to highlight the work of one of our psychology interns. He's finishing up internship here and has done some great work on ART, antiretroviral therapy, medication adherence among people who use alcohol. And so in their research, he's found that they basically identified that there are these different types of responses that result in lower ART or antiretroviral therapy in adherence. And so some of them are intentional, where people get the idea that using the alcohol and then also taking their medication for HIV has a risk in and of itself. And so this is based on faulty information for the most part. And then in that case, that person will make a choice if they want to drink and they don't want to have that interaction with the ART medication. They just will not use the ART medication. And so we know that by not being adherent to the medication, that there's the risk of an unsustained viral suppression. What we want to do is get the viral load down so that it's undetectable. And when it's undetectable, there's a less likelihood of passing it on to someone else. But with people sometimes making the choice not to take the medication because they don't want it to interact with the alcohol, that risk is there. And then so that one is intentional, and then there's unintentional. And so sometimes people drink and they forget things. So there's the being so involved in your alcohol use that you forget your medication or it becomes less of a priority. And so I thought this was just really interesting work, being able to tease out those unintentional and intentional mechanisms associated with lower ART adherence. And so going on from there, looking at other substances, the different substances have different and sometimes overlapping risks associated with them when it comes to HIV and other sexually transmitted infections. So with opioids, we know that needle sharing, because oftentimes opioids are injected, needle sharing is a risky behavior. And also risky sexual behaviors come along with that. Again, lowered inhibition and change in cognition. And we have similar things for methamphetamine. And with crack cocaine, the research has found that transactional sex, so trading sexual favors for money or drugs, trading sex to get things that are needed, is associated with crack cocaine use. There are, and this is usually common among women. And then there are other substances such as inhalants. So this substance is often referred to as poppers. In the United States, it's amyl nitrate. And it is actually used to enhance sexual experience or just bring on a general feeling of well-being or pleasure. And so it's often used because of that enhancing of the sexual experience. And so that also increases risk for HIV and other sexually transmitted infections. Okay, now I said I was going to mention gender differences as far as substance use disorders. The research tells us that men, in the research here in the United States, men are more likely to use substances and have higher rates of substance use disorders in general. Women, however, have higher rates of non-medical use of psychotherapeutics. So you'll have women who use more anxiety medications or sedatives, prescription pain relievers, sleep medications, but not for their intended purpose. Also, although women are less likely to use substances, when they do start using, they escalate in severity more quickly. And women are much less likely to seek treatment for a substance use disorder. So I mentioned before, like when we're considering women and we're considering mental health and trauma, looking at these gender differences, one explanation for those gender differences in outcomes and severity of substance use and that connection with risky sexual behaviors has to do with what we call gender power imbalances. And so these often result when there is intimate partner violence. So women who are in relationships where their partner is physically abusive towards them are more likely to be involved in coercive sex, have violence against them if they don't engage in sexual activities when requested, and more likely to have multiple partners because a lot of times the intimate partner violence, the violent partner giving that woman as a sexual object is kind of part of their control over her. As far as partner gender, the research has shown that both men who have sex with men and women who have sex with women have higher rates of substance use than their heterosexual counterparts. Looking at men who have sex with men in particular, I've mentioned methamphetamine use before as a substance that's used to enhance sexual pleasure. But methamphetamine use in the research has been consistently linked with risky sexual behavior. And it's believed that it's because it offers increased libido and also decreased inhibition, and it enhances sexual pleasure. A lot of people who, in the research, this article that I cited by Simple, this article states that for men who are already living with HIV, there are a lot of negative emotions associated with that diagnosis. And if they are not getting treatment for their mental health that's connected with their HIV diagnosis, they use substances to dull kind of those negative emotions. And methamphetamine is a substance of choice for that population. So I want to shift a little bit and talk about HIV prevention strategies. As you may be aware, early HIV prevention focused primarily on individual level factors, and that's mainly behaviors. So if you have a person in front of you who you believe is at risk for HIV, then the intervention is educating them about their own individual risk factors, encouraging them to get HIV testing, encouraging them to use condoms, discouraging injection drug use. So all of that takes place on an individual level, and it's all behavioral. So it's about getting a person to change their behaviors in some way. Now, with the medical research, of course, now we have biomedical prevention strategies. So in the US in 2012, Truvada was approved by the US Food and Drug Administration as a HIV prevention pre-exposure prophylaxis or PrEP medication. It was approved in 2012. It is highly effective. You know, people who take PrEP consistently reduce their risk of HIV tremendously. It is over 95% effective when taken as prescribed. However, despite how much we know about how effective it is, people are not using it at the rate that we hope they would be using it. So only about 18% of people who could benefit from PrEP received a PrEP prescription in 2018. The Centers for Disease Control and Prevention has a list of what they call PrEP indicators, and these are certain things that place them at risk. So things like having condomless sex with a person of unknown serostatus, injection drug use, all of the things that we've talked about that are risk factors are listed as indicators for PrEP. And so based on that, researchers can estimate who would benefit from it. Now we see similar disparities in the use of PrEP as we see in the incidence of HIV. So I went over things like differences between men and women, differences in age, and also differences according to race and ethnicity. And so here are the gender differences here. So PrEP coverage basically is saying that this is the percentage of people who could have benefited from PrEP use who actually received it. And so that's the number on the left with the gray bar. 18.1% of people who had PrEP indicators actually received a PrEP prescription. And then you see on the right-hand side in the gold under male, that the majority of the people who do receive it are male, and men are about 3 times as likely to receive a PrEP prescription if they're eligible for it and meet the criteria for it than women are. And there are also racial and ethnic disparities. So again, it's 18% PrEP coverage in general, and you see white men at 42.1%, Hispanic Latino, I'm sorry, it was not white men, but white people in general, 42.1%, Hispanic Latino at 10.9%, and Black or African American at 5.9%. So white people were almost 4 times as likely as Hispanic and 7 times as likely as Black or African American individuals to be prescribed PrEP. So the reasons for low PrEP use are not completely known, but we do have some ideas. So one big thing that comes up in the research is a lack of knowledge. Some people are not even aware that it exists. And I'm going to talk about a project in a minute that I have ongoing, but just I wanted to mention that as little as like a week ago, I did an interview with a person who has PrEP indications, and this was a woman, and she has never heard of PrEP. And so we were kind of exploring why that might be. When I showed her like commercials that exist, she's like, oh, that's what that was. But she didn't really pay attention to it because all of the people in the advertisement were men. So the advertisements were targeted towards men, and it just kind of went by her. She didn't really even pay attention to it until it was pointed out to her. So this lack of knowledge is one of the big things. People don't even know that it's something that can be used. There's also on the provider side some reluctance to assess people for risk. There's reluctance to even refer people. So if they don't want, if the provider themselves do not want to assess for risk, you would hope that they would at least refer to someone who feels comfortable with doing that, but that's not happening either. And then for those providers who can prescribe, there's some reluctance to prescribe there as well. And on the individual level, there's low perceived personal risk. So another person I interviewed within the last week said, I don't think that I need that. I don't do those things. I don't have sex with multiple partners. When I ask about condom use, no, we don't use condoms. Do you use drugs? Yes, I use drugs. And do you know your partner's status? Do you know if your partner is HIV negative? And she said she did not know. So low perceived personal risk, despite the risks existing. And then there are also understandable concerns about side effects and potential drug interactions. So what do we do about it? How do we intervene? So from my perspective, it's really important to consider individual differences when determining an approach to HIV prevention. It's become apparent that there's not one solution that's good for everyone. And so I like to look at prevention with this health promotion continuum. So this is from the Institute of Medicine, and it recognizes that health promotion occurs on this continuum, and that prevention is a pretty big slice of that. And so I'll talk a little bit about universal, selective, and indicated approaches to prevention for HIV. So from a prevention standpoint, we can look at this health promotion continuum as requiring a multi-pronged approach that addresses individual, interpersonal, environmental, and societal factors. So we know that substance use is one of the risk factors for HIV. So in our continued efforts to reduce the negative health and social consequences of substance use, there's been this increasing push to look at all of this from a socio-ecological framework so that we can take a multi-layered approach. So we talked about, or I mentioned universal prevention. So basically what universal prevention is using these broader strategies that focus on developing environmental change or some change in the community characteristics. And so when I think about universal prevention, we hear a lot about systemic problems. I think these universal prevention methods are the way to address these systemic problems. And so some examples include educational activities that target a whole group of people, regardless of their level of risk, mass media campaigns, and of course, legislation is also important. So an example of universal prevention in the United States, Ready, Set, PrEP, comes from the Department of Health and Human Services. And what it does is it provides, there are videos, there are pamphlets, there are handouts, there are decision tools, all kinds of information on what PrEP is, how effective it is, how to find it, how to pay for it, just everything a person would want to know about PrEP. And they have tools available that are intended for a person, a regular person interested in PrEP, and also for providers. So the providers can be more educated. And here is an example on the left of one of the advertisements about how to get HIV medication, how to get PrEP for free. So also for universal prevention, it also involves policy changes and implementation. So for example, we know that needle exchange programs have been very effective in reducing the spread of HIV and other infectious diseases that can be spread through shared needles. Not only is it effective, but it is very inexpensive. And so on the right there, I have a little bit of a quote out of this article about how increasing funding by just a little bit for needle exchange programs would reduce HIV infections, and the cost savings are phenomenal. Unfortunately, there are still states in the United States where needle exchange programs are explicitly indicated as illegal, like Texas, or where there are no protections in the law for individuals who run needle exchange programs. So in those cases, the legislation is so unclear that a person who might want to start a needle exchange program is reluctant to do so because there's nothing to protect them from being arrested and incarcerated for it because it's not clearly written in the law. And here's another place where policy matters. So in 2019, we were really excited to hear that there were provisions in the Affordable Care Act that allowed for PrEP to be rated as an effective preventive service. And under the Affordable Care Act, there are rules in place requiring health insurers to cover the cost of PrEP. And so that news came out and everybody was really excited. Great, PrEP for free, and the insurance companies have to cover it. And so what that did, or potentially did, was, so like programs like Ready, Set, PrEP give you information about how the pharmaceutical companies can help you get reduced or free medication. That's for people who are uninsured. But then when this came out, that meant that the people who were insured also could get their medication without having to worry about paying for it. The problem is that despite that, insurers were given at that time, they were given until January 2021 to make sure that they adhere to that. But still to this day, patients are still complaining that they are being billed for medication. The government went on to clarify that it's not just the medication, but also the services that go with it. So like the medical exam, the lab work that's used to make sure that people are safe on PrEP is supposed to be covered. And even with that clarification, we still don't have I'm sorry, I advanced the slide. I didn't mean to. We still don't have insurance companies fully cooperating with this. So that was about universal prevention. And I want to move on to types of prevention that we as providers are probably more involved in. If you're not a person who is into changing policy or this is a place where behavioral health providers can have a great impact. So that second type of prevention is selective prevention. In selective prevention, there's a focus on developing strategies to help people to make healthier choices and to change their harmful behaviors. And this is like in a case where the specific individual maybe hasn't been evaluated for their specific risk, but they fall within a group that's been identified as having higher risk. So that's like men who have sex with men. We know that they're 67% of the new cases. So any type of intervention that provides information and helps men who have sex with men, regardless of their own individual risk, engage in healthier activities, that's considered selective prevention. And then there's indicated prevention. And in this case, this is where these efforts are focused on people who show early detectable signs of a problem. So you may have a person who is being treated for a substance use disorder, and they mention, oh yeah, I tested positive for gonorrhea or something like that. And as a provider, you might say, hey, you know, this is a time to intervene because your substance use and your sexually transmitted infection puts you in this particular risk category. And so those prevention efforts are targeted for individuals who have shown some signs of being at risk. Okay, I mentioned behavioral health providers a lot because I am one. I'm a psychologist. And so a lot of behavioral health providers are not really comfortable with assessing people for sexual risk or even talking about HIV with their clients. So like I mentioned, most of my work focuses on selective and indicated prevention areas. So I want to talk a little bit about the role that behavioral health providers can play in reducing HIV risk, providing some prevention activities for substance using populations. So it's not showing up. There were some words there, but this is known as, this is what I call the purview paradox. So basically the arrow on the left says that behavioral health providers are better equipped to assess substance use and mental health risk, whereas the arrow on the right says HIV providers are better equipped to assess clients for sexual risk. So the problem is that providers sometimes feel responsible for different aspects of an individual's care, and they might avoid engaging in activities that they feel are not within their area of expertise. And some in the research call that the purview paradox. So if you hear a psychologist saying, I don't talk about sexual risk because that's not part of my job, an HIV provider should do that, then that's what an example of the purview paradox. And so this is challenging for providers. So I don't want to beat up on them too much. It is challenging for providers. Addiction and mental health providers do have contact with individuals who are at high risk for HIV and other sexually transmitted infections, but they often feel like they're not equipped to address sexual health. And sometimes they feel that it's not their job or that they wouldn't do a good job with it. Unfortunately, this results in some gaps in care. And so, you know, we all know that, you know, mental health and physical health are connected. And so if a mental health provider is the trusted provider of a person, then the hope is that that trusted provider would also be concerned about their client's mental health. I'm sorry, about their physical health. As far as the clients, there are challenges for them as well. So some of the providers say if this client wants information on preventing HIV, they should just ask for it. But there are other challenges, including mistrust of healthcare providers. Sometimes a patient may see a doctor for their mental health, they'll get their medication for that, but they don't really feel supported by that healthcare provider. So they get the thing that they need from them, maybe a medication prescription, but they won't talk to them about other concerns in their lives. There's also community stigma. So just talking about HIV prevention, sometimes just saying, I'm going to go get tested for HIV can lead some people in some communities to say, what's wrong with you that you need to go get tested for HIV? Not that it's just a good preventative thing to do, but there must be something wrong if I'm doing it. And then there are things that I just sum up as costs and benefits. There are some things that individuals know that place them at risk, but they weigh the costs and benefits of doing it. So for example, a client might be aware that there is a consequence related to sharing a needle when they're using a substance. But if they're self-medicating for psychological symptoms with that substance, then the benefit is I'm going to get rid of all of my anxiety and let my stress go just by using this needle. I'll take the risk. And so those are things that clients struggle with every day. So just to kind of sum it up, we just really can't wait for our clients to bring these concerns to us. It's really important that we remember this health promotion continuum and that we ask the questions so that we can get the clients the help that they need. So I'm going to shift gears and talk about some of the programs we have going on here at UT Health. So this is a program that I have. It is called the HEARTS program, and it provides HIV prevention through education, through HIV testing. It is meant to be for people who use substances, and it is meant to be for people who SAMHSA has decided are underserved in the community. And so it's in my particular project, it's primarily targeting ethnic racial minority and also people who identify in the LGBTQ, so lesbian, gay, bisexual, and also transgender persons. This project is funded by the Substance Abuse and Mental Health Services Administration, and we have had some success. It's been going on for almost 5 years now. And so it's probably a little bit hard to see, but the primary outcomes that SAMHSA is interested in is like when we start, how many people report abstinence from a substance in the first month. Abstinence isn't always our goal, but we do see here that for the people who completed the 6-month follow-up, that there are more people who report abstinence after the 6 months in our program. And we can look at some of the mental health outcomes as well on the next slide. So far as of March, well, not so far, but as of March 2022, we've served 267 individuals, and we're also showing some good mental health and substance use outcomes with decreases in alcohol, cocaine, and marijuana use after 6 months in the program, and also decreases in depression and anxiety after 6 months in the program. And so this is one of those programs. It's not a research program, it's delivering services, but it's when we talk about the different ways, the different methods of prevention, providing the services to people who do not normally access them is one of the important things that I see, and this is something that we've been very successful with. So I just wanted to share that one. We're also doing some research, and so I mentioned that I am very interested in women's mental health and preventing HIV among women. And so trying to understand some of the things that keep women from using PrEP is an important area of research. And so this is one of the studies that we did looking at barriers to PrEP and also generally engaging in HIV prevention. And so for this particular data, we looked at anticipated stigma regarding use of PrEP as a factor for possible underutilization of this important prevention strategy. And so we looked at the relationships among PrEP stigma, sexual risk behaviors, which we defined as condomless sex or inconsistent condom use with persons of unknown serostatus, and sex in exchange for money or drugs. And we also looked at substance use attitudes towards HIV testing. These were 106 women, primarily ethnic minority women, who had reported recent problematic substance use. And all of the women had at least one of the indicators from CDC for PrEP, meaning that they would be appropriate for PrEP. And I know it's a little bit hard to see, but some of the questions that we asked are in the slide there. So things like at the top, when we're looking at PrEP user stereotypes, I would be ashamed to tell other people that I was taking PrEP. And the darker squares on the right of that are those people who responded affirmatively to that. The second question, people would assume that I am HIV positive if they knew I took PrEP. Over 50% of those women endorsed that one. And at the bottom of that section, people would assume I slept around if they knew I took PrEP. And again, over half of those women said they agreed or strongly agreed with that. And so this gives some indication of some of the barriers that women have in engaging with effective HIV prevention strategies. Highlighting another intern. So this is another intern who's finishing up. She presented on HIV testing barriers, and this was also with ethnically and racially diverse women. She also looked at medical mistrust and discrimination as predictors, and she has some interesting findings there. She first did a confirmatory factor analysis where she found two factors for medical mistrust, one being medical suspiciousness, and I can't see because my eyes are bad. Oh, the other's discrimination. So what she found was a few things, but interestingly, lower medical suspiciousness is associated with a greater likelihood of recent HIV testing, and greater medical suspiciousness was associated with a lower probability of testing, especially with people with problematic substance use. And we're working on expanding this. This was a poster presentation at a conference just 2 weeks ago, and we're working on expanding this to a paper and hope to get it submitted for publication soon. As far as ongoing research, I have a project currently about understanding barriers to HIV prevention. This is funded by the Texas Developmental Center for HIV Research. And the purpose of this study is to kind of look at intersectional barriers to engagement in HIV prevention. So we're also interested in this study in looking at perceived stigma, medical mistrust, health literacy, and willingness to engage in integrated HIV prevention and substance use disorders interventions. Another thing that we're adding is that we're exploring provider attitudes about HIV prevention for individuals with problematic substance use. So it's a mixed methods approach where we've collected the data for the first phase, which is a quantitative phase. Yes, it's there. Where we were looking at individual characteristics that impact the likelihood of engaging in HIV prevention strategies. So we've completed data collection there for the quantitative portion of it, and we're in the process of conducting interviews about knowledge and attitudes for HIV prevention and barriers. So a couple of the little kind of anecdotal pieces I gave earlier about responses to some of the questions are from interviews in this project and the next project I'll talk about after this. All right, and so we're also interested in developing interventions. So before I talked about like delivering services, increase access, and then I talked about understanding the barriers. We're also interested in intervention development, and this is one of my co-investigators on 2 of my projects. Mandy Hill is the lead author on this. What Dr. Hill did was she developed it's an interesting intervention. It's a tablet-driven, it's a questionnaire where the intention is to get some information about what people know about PrEP and their awareness, but at the same time, there are little messages embedded within the questionnaire on the iPad that gives them information about PrEP, where to find it, and things like that. So it's kind of a sneaky way to do an intervention while also collecting some data. And it's a really small study, but it did show some effectiveness that by the time the person completed that questionnaire with the embedded messages within the questionnaire, that they had changed their minds about how interested they would be in exploring PrEP. So that's a step forward. Also under intervention development, I have a grant funded from the National Institutes for Drug Abuse on developing and pilot testing a PrEP uptake and adherence intervention for women with trauma related mental health conditions. And so the goal there is that we would like to establish clinic-based behavioral intervention for increasing PrEP uptake. The idea here is, as I mentioned before, the mistrust of the medical system is a really difficult barrier to overcome. But for a person who is in treatment for their mental health condition, they have established a relationship with that provider and with that clinic. And the hope is that by putting the HIV prevention services in a setting where they already feel comfortable, that we might be able to increase engagement in PrEP. And so this one is just starting. We've done some interviews with that one too. So AIM 1 is the interview phase where we're collecting information on knowledge and attitudes. We're also showing them a proposed intervention and asking for their feedback on what an intervention might look like, what would be acceptable for them. And it's based on a framework called IMB. It's information, motivation, and behavioral skills. And so the interview guide is based on IMB. So we want to know what information they already have and how they prefer to receive information. We want to know what motivates them to engage in health promoting behaviors and what could motivate them to engage in PrEP or an intervention that gives them information about PrEP. And then we also want to teach them behavioral skills for being effective in their HIV prevention. And then finally, once we collect this data and create and tailor this intervention for this specific population, we'll do a randomized trial with about 60 people. And these are the investigators with that. And then upcoming research is another intervention development project. And this study is quite similar, but it is focused specifically on women in treatment for substance use disorders. And similarly, it's mixed methods. We will do interviews with women in treatment, and we will develop the intervention based on their feedback and the things that they feel are important for an intervention. And then we will test that intervention. And this one is funded by the Centers for Disease Control and Prevention. So there are a lot of exciting things all happening at one time. It's like, I say, it's like feast or famine around here. We struggle to get funding, and then we get all the funding at one time. So I'm not going to complain, but we're working hard right now to get these projects going. And these are the investigators for this one. So we come about to the end of the time, and I just wanted to summarize. There was a lot to cover there, and so hopefully it's something in there was interesting to someone. But to summarize, there have been some significant gains in HIV prevention efforts in general, and the substance using population benefits from those gains. However, despite those efforts, the progress has slowed in most recent years. So we're like at where we've reached a place where things are not, HIV rates are not decreasing at the rate that we want them to in order to reach that ending the HIV epidemic plan for America. The benefits of HIV prevention efforts are apparently not readily available to all populations. I and other researchers believe that that's the reason for the stall, that we're reaching certain populations but not others. And until we're able to get those strategies available and used by everyone who could benefit, we're going to stay at that level. So this is why the work I do focuses on tailoring interventions to reach specific populations that have not traditionally benefited. Mental health and substance use disorders providers are in a great position to have access to populations who are at risk for HIV, who are not right now benefiting from the HIV prevention strategies. So tailoring those interventions and making sure that we get providers involved in the process is going to be an important part of ending the HIV epidemic. And so there are some select references there. I mentioned my funding sources, and there they are here. And I also like to acknowledge my team. So these are some members of the HEARTS program and also the Center for Neurobehavioral Research on Addiction. And this was all of, well, not all of us, a lot of us attending the conference I mentioned just a couple of weeks ago. And so I couldn't do any of this work without having this great team. Thank you very much for your attention, and let me know if you have questions.
Great, thank you very much. That's a lot of work, a lot of information in this huge area. And so I'd like to congratulate you and your team for this wonderful work related to diagnose, treatment, prevention, all kinds of strategies and efforts to improve this difficult area. So I think we have some questions here, and I'd like to read you. Pessoal, vocês podem mandar perguntas em português que a gente vai traduzir. So the first question is, are inequalities between genders and linked to the patriarchate culture an influence, for example, the risk for HIV and AIDS, since it influences how women negotiate condom use?
Yes, so that is one of the big things, and so for condom use, you require some cooperation. So a woman could know how to request their partner use condoms and know how to set those boundaries, but if there is an imbalance in the relationship, then they may not always get that for themselves. And that's where PrEP is so promising, that if a woman can take PrEP, even though condom use is still recommended, it at least gives them some protection that they themselves have control over.
Great. I read in one of your papers that there's a lot of stigma and barriers for these women to say and tell people that they are using PrEP, isn't it?
Yes. So there's a lot of stigma. I mentioned the higher HIV cases in the South, and I also mentioned the needle exchange, how it's illegal in a lot of states in the South. It's interesting in the United States that the southern areas are very conservative and often very religious, and so there's a real concern that people in the community might judge a person for using PrEP or for using a condom or for getting an HIV test. And that's really a salient problem, especially for women, where social support is so important. You may be doing something to protect your health, and then at the same time losing the people who are supportive of you in other ways.
Yeah, that's a sad and risky scenario. I remember 20 years ago, we were worried about cocaine injectors. Do you still have cocaine injectors in US, or only crack users right now?
There are some people who inject cocaine. It's rare. For the most part, like crack cocaine is cheaper, easier to get. So the majority of people use that. And then the second largest users snort. So the injection use for cocaine is rare.
Okay, this is a similar scenario regarding Brazil. So we have a question related to crack. Elcio wants to know how is the crack problem and HIV and sexual risk in this population in US?
So hopefully I'm understanding the question. In the US, so crack cocaine was the big drug in the 80s. The population that used crack cocaine is still using it. They are older. So we have a lot of people in treatment for crack cocaine who are in their 60s. So it's still there, and but not very popular among younger users. As far as the HIV connection, a lot of that has to do with the women who use crack cocaine, because they're often using it along with trading sex. So a person who is addicted, a woman who's addicted to crack cocaine, can get it if she agrees to have sex with a person who can get it for them. So that's where the risk is primarily there. So we see more of that connection with women who are in sex work.
Thanks, it was clear. So regarding to PrEP, you can get PrEP only with health insurance, or government give PrEP for some populations. How government is trying to get more PrEP to people right now, to give people right now?
Yes. So the first company to be approved for their medication for PrEP was Gilead. Seeing how effective it is, they created a PrEP prescription program. So if a person has insurance, sees a doctor, and is prescribed PrEP, they have a program, if they have insurance, to allow them to get it with a reduced copay. So the copay is the part of the cost of the medication that people with insurance pay. And so Gilead agreed to reduce that copay for people who apply. And then for people who don't have insurance, Gilead had a program where they would give the medication for free. So this was before the US government said that this is a very important prevention. And so even people who have insurance, they should have no copays. There should be no cost for it at all. And they mandated that for insurance companies. However, insurance companies are finding ways to get around it. So there are formularies for the medication. If they put the medication in a different spot on the formulary, then it will automatically bill the person for it. And so people who should be getting the medication for free are being charged for it. If they complain, so each state has a Department of Insurance. If the patient complains to the Department of Insurance, the insurance company can get in trouble, and the patient won't have to pay for it. But a lot of people don't know that they can do that. So rather than going through all of this trouble, they'll just say, I'm just not going to take the medication.
Great. So there's another question from Elaine Camarini. Do you think it's valid to work with peers to diminish the stigma?
Peers, do you mean my peers, or do you mean the peers of the potential person who could benefit?
I think from the specific populations with group and peers.
Yes. Yes, definitely, both ways actually. But for peers of the person who could benefit from PrEP, so to reduce stigma, There has been some research, so a couple of things. So there's research on partners, so making sure that partners, sexual partners, get the same information about PrEP, and that's been helpful to reduce the stigma there that they might get from their sexual partners. And then there are programs, just like in substance use recovery, where there are peer experts, so people who have lived experience of substance use sometimes work with other substance users, and that helps them to navigate the system and feel like they're supported. There's some beginning research on using like peer navigators to navigate HIV prevention and PrEP, and that's looking very promising as well.
Okay. Another question by Katja. So regarding opioid use, heroin injection. So how is the opioid epidemic right now, and how it can maybe influence this whole HIV risk?
Mm-hmm. The HIV epidemic is still raging strong here in the United States. And for those who inject opioids, like I said before, be it heroin, and sometimes people also take the opioid pain medications and reduce them down so that they're also injectable. Anytime needles are used, then we know that that's a direct risk for HIV. And there's also the, even if it's not injected, if it's used in pill form, there's that judgment thing and the cognition part of it. Yes, the opioid epidemic is definitely contributing to us not being able to get the rates of HIV down. They're a part of it, and also should be considered when we're intervening.
And what about marijuana legalization? Do you think the whole thing is also contributing?
So I don't have research data on that, but in my opinion, probably.
Okay.
Yeah, I think it would be really neat if someone looked at like the states where the laws have changed and it's legalized, to see if there are any changes in HIV rates in those states. It's a good time to do that because it's a transition period where there are only a few parts of the United States where it's legal, and federally, according to the federal government, the United States government, it's illegal still, but there are certain states where it's legal. And this is a great time to do some comparisons for those states where it is legal versus where it is not legal, and also some before and after from within the states where it changed.
Okay. Your opinion is very important to us. I know some issues are very difficult to get good data.
Mm-hmm.
So regarding your opinion, are you optimistic about decreasing HIV and incidence and prevalence, even with this whole drug culture in the United States, or not?
Well, I have to be a little optimistic, or I would have given up by now. I am optimistic. I think there are a lot of things that we can do. It's just that so far, people have been looking at it from only like one angle, and it really takes everything. It takes working with people individually and working with the providers, and then also changing laws, which I always say is above my pay grade, but we can always lobby, for changes in the laws. So yes, I am optimistic. It's slow. I don't personally think that we will reach that goal that was set. The goal will probably move unless there's a miracle. But yes, I am optimistic. Things definitely can change. PrEP has been a huge game changer. And I didn't mention the injectable PrEP was recently approved. So now a problem for the people who actually get it is remembering to take a pill every day. Now people can get an injection every 2 months. And so I think that's going to also be very helpful.
Okay, people are commenting here that it would be interesting to compare states regarding marijuana legalization and HIV and maybe risk behaviors. So I agree with them.
Me too.
I think we don't have more questions. Maybe I would ask you a last question related to prevention. If you had a lot of money and you can develop a very huge national program, prevention program, in order to address this HIV, drug use, stigma, what kind of project would you do?
I had a lot of money.
Yeah, a lot of money. Don't worry about it.
Don't worry about it. I would definitely create more needle exchange programs. That by itself, if people could just easily have clean needles, would knock out a whole lot of that injection part, which was a pretty significant portion of the new cases each year. Definitely expand the needle exchange program. The HEARTS program that I have is in its little way increasing access to substance use disorders treatment. And just because they're in the program, they also get the HIV education, and the testing is right there. I would want all mental health and substance use disorders treatment programs to incorporate HIV prevention. And I would want physicians trained to just automatically ask about substance use and sexual risk. That I have a long wish list. So if I had all of that money, yeah, those are the things that I would change.
Great. So some kind of harm reduction and intervention and treatment. So
And
do you think
and training for providers.
Training for providers. Do you think physicians and psychiatrists are really worried about this, or they are not involved with this kind of things?
For the most part, they're not involved. So as part of one of those projects I mentioned, we are going to interview mental health providers, including psychiatrists. We're going to interview both substance use disorders providers and psychological services and psychiatry services providers on their attitudes. I think that a lot of times they, especially here in the United States, I'm not sure how it is in Brazil, but in the United States, when a psychiatrist sits down with a patient, it's about refilling their medications, and they have very little time. So, 15 minutes, they're in and out with a prescription. And so there's not a lot of time for them to talk about those things. So I don't think it's on their minds. And I would like to see a change.
That's not a good thing. So I think we don't have more questions. 1 hour and a half almost. So we'd like to thank you again. And it's a beautiful work, and we hope to see good data in the future. We felt more optimistic, but we know that there's a lot of work, hard work in this area. And we hope to help you and to follow your example here in Brazil. Thank you very much.
Thank you so much for inviting me.
So I think